Greetings. Let us talk about portal vein thrombosis in the absence of cirrhosis. How do we manage this problem? I want to thank many who support this venture, and please take a few minutes to review this notice. So, portal vein thrombosis, especially recent thrombosis, patients usually present with abdominal pain that is disproportionate to the physical findings. And when you do an ultrasound or a CT scan, you will notice a thrombus in the portal vein, and portal vein is at the site of the thrombus is slightly bigger, and maybe there might be a little bit of contrast going around the portal vein. So these are the findings of portal vein thrombosis. In addition, you should always check whether the patient has bowel ischemia. And when patients develop bowel ischemia, the pain, which is usually in the epigastric right upper quadrant, moves to below the umbilicus, and they have ileus. They may have fluid in the abdomen a little bit, and on labs you usually see elevated white cell count and LDH, and there may be lactic acidosis as well. In portal vein thrombosis, you should start anticoagulation, and when there is bowel ischemia, you should also check whether there is infarction from ischemia, and if there is an infarction, patient will require surgery. Unlike simple portal vein thrombosis without bowel ischemia, patients with bowel ischemia require a team approach consisting of a surgeon, an interventional radiologist, a hematologist, and a gastroenterologist. And the team approach is really critical in managing these complex patients with portal vein thrombosis and bowel ischemia and maybe infarction. When it comes to anticoagulation or antithrombotic therapy in the setting of recent portal vein thrombosis, recent is anything presenting acutely or less than 6 months in duration. Chronic is more than 6 months in duration. So treatment of recent thrombosis of the portal vein is anticoagulation. And what does it do? It prevents bowel ischemia by allowing the clot to dissolve and reestablish the flow. And by doing that, it also prevents the development of chronic venous thrombosis and chronic portal hypertension. So, two benefits: prevents ischemia, prevents chronic portal hypertension. So, coming to the anticoagulation therapy of a patient with recent onset of portal vein or mesenteric vein thrombosis, we have several different options. These include an infusion of unfractionated heparin or injection of low molecular weight heparin into the subcutaneous tissue, or in the tablet formulation, classic oral anticoagulant, that is warfarin, and the newer anticoagulants are direct acting oral anticoagulants. Several of them, apixaban, rivaroxaban, these are the things you want to keep in mind. Rivaroxaban and apixaban. So when it comes to how do you manage anticoagulation, the first step is initiation of therapy. when it comes to initiation of therapy, you have two options. One is intravenous heparin, unfractionated heparin, and the other one is subcutaneous injection of low molecular weight heparin, usually given twice a day. So, what are the pros and cons of each of these two regimens? In terms of efficacy, the low molecular weight heparin is much more efficacious than unfractionated heparin. And because it's a low molecular weight heparin, it has less risk of heparin-induced thrombocytopenia compared to unfractionated heparin. So something to keep in mind. And unfractionated heparin has a very short half-life, a few minutes to less than 2 hours, compared to low molecular weight heparin, which usually goes from 6 to 12 hours. So this is important to keep in mind if you want to use a drug that is very short acting and you can stop it and the anticoagulant effect is gone, especially in the setting of thrombosis and then worried about possible bleeding also. And unlike low molecular weight heparin, which does not require any monitoring, intravenous unfractionated heparin requires close monitoring using partial thromboplastin time or measuring the X factor 10A. Although low molecular weight heparin has a lot of advantages, it cannot be used in renal failure. So when you have renal failure and you have acute portal vein thrombosis, go for intravenous heparin infusion. So we decided which way to go to start the therapy. And once you start the therapy, you have to do maintenance of therapy. And what are the options? We have 3 options here. Low molecular weight heparin injections twice a day, orally giving warfarin once a day, and then direct acting oral anticoagulants, either once a day or twice a day, depending upon the medication. So between these 3, you go with low molecular weight heparin whenever you have doubt that an oral medication may not be absorbed if the patient has bowel edema. So if there is bowel edema and you're choosing between the 2, go with low molecular weight heparin until the edema resolves, and then if you want, you can shift to one of the oral medications. Patients with malignancy, also low molecular weight heparin is preferred, although other 2 also work well. However, if the patient has renal failure, as we talked about, renal failure is a contraindication for the use of low molecular weight heparin. The others can be used in this setting. And finally, low molecular weight heparin does not require any monitoring, while warfarin requires monitoring, and direct acting oral anticoagulants, they do not require monitoring, but you want to see whether they're working or not. You can check factor A level or one of the coagulation tests for other direct acting oral anticoagulants. So you started the therapy, you put them on maintenance, and then you have to figure out how long are you going to continue therapy. So when it comes to that, you need to go back to the history. What was the reason for portal vein thrombosis? Was there a precipitating factor, or did it happen without a precipitating factor? And when it comes to precipitating factors, there are 3 important factors. One is inflammation. It could be any inflammation inside the abdomen, diverticulitis, colitis, appendicitis, cholecystitis, pancreatitis, or injury, blunt injury to the abdomen or surgical injury to the abdomen, like surgeries on the stomach, gallbladder, pancreas, spleen, and colon. Any of those surgeries can be a precipitating factor. And so you have to ask yourself whether there is a precipitating factor. If the thrombosis happened in the setting of a precipitating factor and the patient has no history of prior thrombosis and there's no family history of thrombosis, then you can stop the medication after 6 months. So the duration of therapy in somebody who has a precipitating factor is just 6 months. On the other hand, you look at the history, you can't find a precipitating factor. And in that case, you always have to look for thrombophilic conditions like myeloproliferative syndromes or factor V laden mutation, prothrombin gene mutations, protein C, protein S deficiency, or anticardiolipin antibodies, or any of those that can cause thrombophilia. You should check. And if they are positive, then you treat them for long-term, indefinite therapy. So when you're thinking about portal vein thrombosis, few things are important in the acute setting. One, is there a precipitating factor? No precipitating factor. If there's no precipitating factor, look for thrombophilia or no thrombophilia. And then presence or absence of ischemia, presence or absence of edema of the bowel, to decide how you're going to pick your treatment and how you're going to manage the patient. If the thrombosis has gone for 6 months or longer, or there is complete occlusion of the portal vein with cavernous transformation of the portal vein, then that patient is at risk for portal hypertension. And you should check for varices with endoscopy. And if they have high-risk varices, large varices, varices with red wale sign, cherry red spot, you should consider non-selective beta blockers. And if there is a contraindication to the use of non-selective beta blockers, then you go for band ligation. And how about anticoagulation? We talked about anticoagulation for portal vein thrombosis, but in a complete occlusion with cavernous transformation, there is no need for anticoagulation. But on the other hand, you're monitoring these patients and you see that new thrombus is forming or thrombus is extending, or if the patient has thrombophilia, then it's a different setting. In that patient, you may consider anticoagulation. There is no role for interventional radiology in this setting, especially when there is complete occlusion with cavernous transformation of the portal vein. When it comes to band ligation, current guidelines suggest to hold anticoagulants. Although there are some case series, short case series, where they've shown that band ligation could be done without interruption of the anticoagulation, until we have a little more evidence. For now, it is safer to hold anticoagulants before band ligation. I hope this is helpful, and I want to thank these two groups that have come up with beautiful guidelines, and most of what I've shared with you is based on reading these two guidelines. Thank you.